Afternoon, everyone, and thank you for logging in for these weekly teaching sessions. And I'm quite looking forward to today's session because I think this is one of the topics which we um, read less, discuss less, and part of that problem is also that the hemophilia care is kind of quite centralized in few institutions, and I think most of us do not get a lot of experience and the patient load to be dealing with hemophilia directly as much. So I should thank Neeta for volunteering for today's session and also bringing a battery of experts to discuss today's topic, and and she has tried her best to involve people from different kind of fields of hemophilia to be talking to us today. So as usual, we'll have two components to today's session. There's a didactic, there are two didactics in fact today, and that's going to be on investigating a child with hemophilia, and also very important price and home care in hemophilia. We've got Dr. Srimati Shetty and Dr. Pamela are going to be discussing, doing the didactics, and then post that Ravi Shankar is going to be presenting the case on hemophilia, and we'll have the experts discussing the case. So I'll also, take this opportunity to introduce our faculty for today. Anita, is the moderator for today's session, and we know her. She's a senior consultant hematology-oncology at the Specialty Hospital Noida. We have Dr. Tulika Seth, who doesn't need introduction to this audience as well. She's a professor of hematology at All India Institute of Medical Sciences, Delhi. Dr. Srimati Shetty, scientist E and deputy director at NIH Mumbai, and we have been interacting with her for so many years now, and she has been providing extreme, support and help in working out a lot of these patients. So thank you very much, Dr. Srimati, for your time and sharing your experience with us today. We also have Dr. Uday. He is a good friend. He's a professor of hematology at the RR Hospital in New Delhi, and Uday is also a guest for today's to this audience, and he has been, his contribution to hematology are immense, especially in, I think he does a lot of work in multiple myelomas per se. Dr. Pamela Narayan, who is a senior consultant of physiotherapy at the Lakshmi Neuro Center, Hyderabad, and I think it'll be great to hear her perspective on the home care and other physiotherapy aspects of hemophilia. So over to you, Neeta. So we'll start our sessions now. So as requested, before we were requesting, please keep your videos on and put your questions in the chat box or raise your hand to ask the questions, especially in the case discussions later on. Thank you very much.
Thank you, Sunil. Sunil has already introduced the faculty, and just 2 lines from my side. I'm extremely thankful to all the faculty for the participation despite personal troubles during this COVID crisis. And this is like hearing from the horse's mouth. Each of our panelists have been involved in hemophilia care for the last many decades, and they have been involved in guidelines as well as multiple studies. So I'm sure the next 1.5 hours will be extremely useful to all our trainees. So to start, like Sunil said, we'll have a didactic first on investigations in hemophilia from Dr. Srimati Shetty. Over to you, ma'am.
Thank you. Thank you. Good afternoon, everyone. My screen is visible, right?
Yes, ma'am.
Yeah.
If you could put on the slideshow, ma'am.
Yeah, sure.
Yeah, that's good now. Yeah.
Dr. Neeta, thanks for inviting me for this webinar. Probably I'm talking for the first time to this group. So the topic is laboratory diagnosis of hemophilia. Now, when somebody says, when some patient walks into the laboratory with a bleeding disorder, many people immediately presume that it's hemophilia. I've just put this slide to show that besides hemophilia, there are a whole series of both coagulation factor deficiency disorders as well as platelet function disorders. Now, just to get an idea as how many, the proportion of this disorder, 90% of them, as you see in the pie diagram, 90% are hemophilia, but you have 10% of, you have to keep in mind that all patients, all bleeding patients are not hemophilia. There's a little older slide till 2016, what we saw at NIH. These are the platelet function defects. The Glanzmann's thromboscythemia is the commonest, followed by Bernard-Soulier. And then you have a big group of unclassified platelet function defects with mild bleeding manifestations. They need a diagnosis because many a times this group is kind of misdiagnosed. Now, just to give a basic background on primary hemostasis, I'm not going, because the time given is just 10 minutes, I'm not going into the basics of anything. So you have primary hemostasis where platelets and the endothelium are mainly involved. So VWF and the platelet receptors, this is what we diagnose whenever a patient is suspected of primary hemostasis. So the platelet receptors are being studied by flow cytometry, and VWF, there are different types of assays. Once the primary hemostasis, the primary plug is formed, the secondary hemostasis takes over. This is an arbitrary coagulation cascade, the intrinsic pathway, extrinsic pathway, and the common pathway. The beauty of this cascade is you have 3 different screening assays to show which arm of the coagulation cascade the defect lies. Nobody should forget that in case of cases which you are not able to explain, the defect may be in the fibrinolytic cascade. We have at least 10-15 cases of congenital deficiency of fibrinolytic factors. So it's not that rare. I mean, it is rare, but you have to keep in mind when you're not able to explain a case and when there is a definitive bleeding history, you should look into this. So this is a summary of the whole hemostatic process. Now, when you come to the laboratory diagnosis of bleeding, these are the 4 important things you have to keep in mind. The diagnosis will not be complete without these 4 factors. Clinical proforma, extremely important. By the end of the when you finish filling the clinical proforma, you have at least 25 to 30% of the diagnosis. Family history, family tree, very important. Then you have the screening tests. They're very cheap, but they're very important. And the confirmatory test to give a final diagnosis. Blood collection, the quality control of in a coagulation laboratory is extremely important. You may give any kind of reports if you don't have a QC in the lab. So citrate, everybody knows trisodium citrate, 3.2% is the anticoagulant for all the coagulation tests. The ratio is extremely important, 9 of blood to 1 of anticoagulant. Clean manufacture, broad gauge needles. Heparin is an inhibitor of blood coagulation. You cannot work with heparinized samples or collected from the venous lines. Use of tubes. You cannot use glass tubes for blood collection because glass is known to activate the coagulation cascade. Correct filling of the tube. Icteric, lipemic, hemolyzed samples may give erratic errors. Now, besides that, the hematocrit is extremely important because your anticoagulant ratio is adjusted to the plasma and not to the whole blood. So there is a formula to adjust the citrate concentration. When the hematocrit is too low or high, you have to adjust accordingly. Clinical proforma should be there. And we have a minimized bleeding score form where if the bleeding score is less than 2, we don't take it for any workup. We ask them to come after 6 months if they have any more, because we end up taking all non-specific bleeding cases. So we have a bleeding score form in the lab to take only the specific cases. The family history, as I said, the consanguinity, both the sexes being affected, the bleeding history and other, extremely important before you go to the actual laboratory test. Screening coagulation tests. Any bleeding disorder, any patient with bleeding when he walks in, you have to have a CBC and peripheral smear. Because if the platelet count is not normal, there's no point in going ahead with the platelet function or coagulation factors. So after that, you go to the 3 very famous screening coagulation tests, PT, APTT, and TT. And finally, there is a simple factor 13 screening assays. To call as a coagulation lab, you have to have, these are the minimum tests a lab has to have to call, designate itself as a coagulation lab. These can be available only in some of the tertiary care centers. These are mainly for VWD workup. You need a big series of specialized investigations. This may not be there in all the coagulation labs. Now, this is the interpretation of the initial screening coagulation assays. It gives you a clue as which of the factors the patient may be deficient in. Let me not get into the details. Everybody knows about it. Mixing studies, I have seen in the CMC quality control, the list of the labs. There may be about 500 to 600 labs doing PT, APTT, but none of these labs do factor assays. When the assay is so simple, you just do it. You don't have to have the level. Just do a mixing APTT with factor 8 and 9 deficient plasma. You are able to give a diagnosis of factor 8 or 9 deficiency. I'm still unable to understand why a modified APTT these labs cannot do, why the patient has to travel kilometers, thousands of kilometers to have a factor assay diagnosis. So the diagnosis of hemophilia is simple. You have an isolated prolongation of APTT. You go for the commonest factor, factor 8. If that is normal, you go for factor 9. Now, if it is factor 8 deficient, it's very important that you rule out VWD. This is extremely important. All factor 8 deficient cases are labeled as hemophilia A by many of the laboratories, which is wrong. So if factor 8 is normal, you go for factor 9. You don't have to do any other assays. This is an important slide. Many times we say that when the screening tests are abnormal, you go ahead with the factors. But for different factors, there are different threshold values. Less than 30% factor, the APTT may be normal on many occasions. So in the presence of even occasional bleeding, if the screening coagulation tests are normal, please go ahead and do the factor. You may end up having a 32 or 35% factor rate despite the APTT or PT being normal. So that's very important. In the presence of clinical bleeding, you please go ahead with the factor. Now, having normal or abnormal levels depends on other factors related to APTT or PT. Now, there are different factor assays, there are different methods, but the most widely used assay is the one-stage assay, which is cheap, which is user-friendly, and the technique which is used throughout the world. But you have the two-stage assay, the chromogenic assay, the ELISA for detection of factor 8. But these are not routinely used. Chromogenic assay is considered as the gold standard assay for factor 8 levels, which is not being interfered by any other factors in the plasma. But at the same time, it's very, very expensive. Now, this is the one-stage factor assay. You need 3 reagents. You need the patient or the control plasma. You need an APTT reagent with the contact activator, and you need that specific deficient plasma. If you're doing factor 8 assay, factor 8 deficient, if you are doing factor 9, factor 11, or factor 12, or any other factor, you have to have the specific deficient plasma. So this is the test. You have a reference plasma. When I say reference plasma, it should not be just normal pooled plasma. Normal pooled plasma with the known level of factor 8. If you're doing an in-house normal pooled plasma, you always calibrate it against a standard, WFH standard or whatever standard, a calibrator whose level you know. Each batch we prepare normal pooled plasma once in 3 months from known controls. We have about 200 to 300 aliquots which are being put into the liquid nitrogen or minus 70-degree freezers. But before putting, we have a WFH calibrator with a known value and we calibrate it. It may be 90%, it may be 120%. So the next 3 months, your patient's levels are being compared to this 120% or whatever level you get for NPP. So this is very important because many of the labs, the normal pooled plasma, they just collect it from 20 controls and they pool it and they put it as 100%, which is wrong. So the assay is simple, diluted plasma, factor depth plasma, and the APTT reagent. You do the same for all dilutions of reference and the patient. Then you plot a graph. This is the graph. So from the first dilution, you go down and you get the actual percentage of factor 8. At least 3 dilutions one should be doing to get the actual factor levels. Now, the units are generally being given in percentage in our country, but if you go to Western countries, it's an IU per DL or IU per ML. 100% is corresponding to 100 IU per DL or 1 IU per ML. So when you refer something to internationally, you have to put it in IU per DL because it's the same as percentage. But when it comes to IU per ml, it's naturally once it's 100 IU per DL, sorry, it works out 1 IU per ml. Now the normal range is 50 to 150%. Now a little bit on the reference plasma I just mentioned, you can have a commercial source with the known value or in-house NPP calibrated against the reference. So this is how we prepare our NPP. Since this is mainly the clinical group, I will not get into the details of the technique. So then we calibrate our NPP against a known standard. Here, the value what we got is 67, which is not the required. We have to have around 100% to be referred to as a good NPP. This is too low value. Factor deficient plasma, you can have an in-house, but it should be 0%. Even with 1.5, 2%, which you have misdiagnosed as less than 1% can give problems. So, and it should be negative for inhibitors as well as for all the TTDs. This you should check before you keep it as a reagent in your freezer. APTT reagent, of course, we keep generally one low phospholipid reagent, which is sensitive to lupus, and one high phospholipid, which we generally use for the factor assays. Because if you use low phospholipid reagent for factor assays or for the routine diagnosis, you may end up getting a lot of prolonged APTTs because of the lupus. So a little bit on the diagnostic, because hemophilia A, you need to rule out VWD. It's a big area. I'm not getting into the details of von Willebrand disease, but at least the first line investigation, if a laboratory gives a diagnosis of hemophilia, they should do at least on the left-hand side, the test, what we do, VWF antigen and one of the functional assays. And if you're not able to do VWF antigen, you can always do REPA with 2 doses of ristocetin. And on the right-hand side, you have all the specialized investigations to subtype the von Willebrand disease. Now, these are the different assays, what is available for VWF antigen. You have a simple immunoelectrophoresis technique, but the drawback of this technique is it can detect only the severe von Willebrand disease. You have an ELISA and you have a latex agglutination assay. Both these are immunological assays. The latex assay can be done in a fully automated coagulometer. This is the REPA, the curves, and this is the functional assay. Now, what is the disadvantage of one-stage assay? Though this is 95% of the labs across the world are doing one-stage assay. It is simple, it can be easily automated. There is a wide availability of reagents. As a result, there is a wide variation in the values also. So most closely related to the physiological system and user-friendly. There are a lot of disadvantages because the APTT reagents, what you use are different. The deficient plasma, you can get affected by lupus anticoagulants. There is a false increase of factor VIII due to activation. All these get interfered in the one-stage assay. Then you have the two-stage assay. When we started off the laboratory, we were doing all those. It's a very tedious assay to do it manual, but this is the assay we were doing earlier. But now we have a beautiful chromogenic assay where you are using a substrate and there is hardly any variation between the laboratories in the NAQUAS quality control program. So the advantages, it is not affected by any of the factors like lupus anticoagulants, factor VIII activation, heparin, thrombin inhibitors. However, we have very limited number of commercial kits and there is less, when the kits are low, even variation is low. And it is not dependent on factor VIII deficient plasma. Very expensive. It is difficult for any lab to use it as a routine technique. But it is being used now in the laboratories whenever there is interference by lupus anticoagulants or when somebody wants to check a product, the efficacy of the product. There is always everybody knows there is a discrepancy between one-stage and two-stage assays. A two-fold difference is generally called as discrepancy, but the bleeding symptoms go well with the two-stage assay and not with the two-stage or chromogenic and not with the one-stage assay. Now, the problem mainly comes when the factor levels are above 1%. In case of severe, both may be comparable. Now, the discrepancy is also related to the type of mutation, so you cannot avoid this discrepancy. So the implication, you may classify a mild hemophilia as normal or a normal as mild when you're using one of these assays. You also have an ELISA for measurement of factor VIII, but this is not being used anywhere. ELISA for factor VIII antigen is not being used anywhere, though the Diagnostica Stego or some other company has these kits. We were doing, when we were doing cord blood sampling for prenatal diagnosis, instead of factor VIII activity, we were using the ELISA kits. Now I'm just giving you how the diagnosis of hemophilia is not so difficult, but the exclusion of other bleeding disorders is a little complicated. This is a 45-year-old lady. She had no bleeding history in the past. Her evaluation showed an APTT of 95 seconds, and the mixing was not correcting 84 seconds. So what we did a high phospholipid containing reagent. The APTT got totally corrected. So this is the advantage of having two types of reagents, low phospholipid and high phospholipid. We did an LA, it got corrected. Now here, APTT is prolonged, 16-year-old boy, consanguineous marriage with similar bleeding history in the sister. So immediately, both male and female, you suspect of von Willebrand disease. But all von Willebrand factor, von Willebrand disease related investigations are normal. Antigen is 94%, REPA is 88%, mixing is correcting. So what is the diagnosis here? So it is suggestive of both the sexes are affected. It is suggestive of von Willebrand. So we did a 2N VWD workup. Binding ELISA we did, and it is 4%, so it is a type 2 normal. So this is one subtype of von Willebrand disease where all VWF related investigations are normal, except that the factor VIII is reduced. If you do not have the female being affected, many a times this normally is classified as hemophilia because nobody does binding VWF factor VIII binding ELISA in their labs. This I have just put many a times. We are getting cases where small kids are being classified as hemophilia without knowing the reference range for children below 6 months of age. Here, if you see, factor VIII is 52%. This had actually come recently to us. Factor IX, 27%. The family was sent to us for counseling. So this is the normal level for a child less than 6 months of age. Not all kids may have this level, but many of the kids below, it all depends on other factors in the child. But factor IX, 27%, 2-month-old child, you can immediately call the child after 6 months, do another factor if you need, just to confirm. Factor VII was 25%. So this is all vitamin K dependent factors being low at that age. So after 6 months, everything was normalized and the child was. Case 4, this is just to show you the technical error. PT, APTT, TT, all prolonged. My immediate diagnosis would be fibrinogen undetectable, afibrinogenemia. But if you don't do a control test, factor VIII level is less than 1%. So this is an improper sample. The lesson what we have to learn from this is, when everything is abnormal in a coagulation lab, you need to do one assay which is supposed to be normal. Otherwise, there may be a minute clot which can give all these erratic readings. So one test has to be normal before you issue a report. So to see that the sample quality was really, and the child ultimately was a factor VII deficiency, which otherwise would have gone as afibrinogenemia. So assays differ, but one-stage assay is still the most user-friendly, cost-effective, except in occasional cases where you really need a level and you can keep a chromogenic kit in your lab and use it only where it is really needed. Otherwise, none of the labs can afford the cost of the chromogenic kits. You can use different types of APTT reagents, vary in their composition. Sometimes you get an APTT of 100 seconds, which we just got 2 days back. And in your lab, it's normal because it is just sensitive to contact factors. So APTT 100 and you are getting 30 seconds and the patient doesn't have any bleeding history. When we check that particular APTT reagent is highly sensitive to contact factors, which doesn't result in bleeding. So all these things are extremely important. When you have a coagulation laboratory, please take part in internal and external quality control to see where you always stand. Little bit on inhibitors. This is a big series, 7,000 patients we screened for inhibitors across the country. Overall, the average inhibitor prevalence was 7.8%, but there was a huge regional variation, with South India showing around 15.6% of inhibitors compared to North India, where it was just 4.5%. So there is a wide variation, probably depending on the factor intake or maybe genetics. So I think I've crossed the time. Now a little bit on the techniques. This is a screening test for inhibitors. This is a table what we use. And then we have a series of quantitative assays. Initially, we had the classical Bethesda assay, very expensive assay because it uses a lot of deficient plasma. But now the standard assay is Nijmegen modified Bethesda assay. We also have an in-house ELISA for factor VIII antibodies. We have big camps for inhibitor screening. What we do is we initially put the whole lot of samples in the ELISA. Whichever is positive, then we take it for the clot-based Nijmegen modified. This reduces the cost substantially. So lupus interference is an important aspect in inhibitor measurement, because 10 to 15% of the hemophilia patients are positive for lupus, which interferes all clot-based assays. Now, how do you escape this? Chromogenic and the ELISA, I know you can just do that to get rid of the lupus interference, but how many of us are affording? See, here if you see, this is a known case of hemophilia. Patient is having an APTT 82.2, mix is not correcting. If you do the NBA assay, more than 128 Bethesda, you are getting even factor 9 Bethesda positive. Factor 8 level less than 1, factor 9 level less than 1. If this is a new patient, if there is no diagnosis of hemophilia A or B, how will you give a diagnosis for this patient? You know that is a case of hemophilia. So what we do, we do an factor 8 ELISA for inhibitors. His inhibitor is just 28 Bethesda unit according to factor 8 ELISA, and factor 9 ELISA is negative. So this is just a lupus interference. Now, how do you assay the factor levels? You go for further dilutions. Instead of 3 dilutions, you go for 6 dilutions, you go for 7 dilutions. Gradually, factor 8 remains the same, but factor 9 gets normalized. So in high dilutions, your factors. So this is one way of giving a diagnosis of factor levels when lupus interferes and all factors are reduced. All right, and then you have a lupus assay, the DRVVT, to confirm that it is lupus. Reagent storage in a coagulation lab is extremely important. Once you take out anything from -70, it cannot go back, or liquid nitrogen. Everything for a long storage should be in -70. Internal and external, we regularly take part, and you have to see to it that your values are within consensus to continue issuing reports to the lab. So this is the same thing what I explained. I'm just showing this. This is with the company now. Very soon, point of care test for both von Willebrand disease and hemophilia. It has been validated both in the Western labs and the internal labs within the country to satisfaction. Now, one company in Bangalore has taken up their licensing, and other processes are going on. Probably in the next 4 to 5 months, it should be in the market. So wherein you can have a diagnosis of severe, less than 5% von Willebrand or hemophilia A within 150 rupees, hopefully. This is how it is. This is a strip. You have to take 2 strips. This is a normal sample you're adding. This is a patient sample. This is how the normal sample looks, both control and test line. And this is how a severe von Willebrand or hemophilia, depending on which kit you're using. Thank you.
Thank you, ma'am. That was wonderful, especially the last bit of point of care testing. It's almost become like a malaria test now, and I hope accessibility to testing improves dramatically. Like you rightly said, all the pre-analytical variables are so important in hemophilia, in coagulopathy evaluation. Almost it's like 1 in 2 to 3 patients that we see need repeat testing and probably have a different diagnosis altogether. Thank you very much, ma'am. I think we'll take the questions towards the end of the discussion, and I'm sure many of these things are being discussed in the case, in between the cases also. Now we'll go to Dr. Pamela Narayan. Like Dr. Sunil introduced, Madam is senior consultant at Lakshmi Hospital in Hyderabad, and she's the Department of Physiotherapy. She's been actively involved in musculoskeletal care of patients with hemophilia. She's associated with the World Federation of Hemophilia MSK committee as well. Over to you, ma'am, for a quick recap on how hemophilia becomes a joint disease and how taking care of joints is of utmost importance.
Let me just share my screen. Can you see my screen?
Yes.
Yeah. Okay, you can see the screen now?
Yes, ma'am.
Yes. Thank you so much, and good afternoon to all the panelists and the attendees out there. I think these virtual meetings are something we still have to get used to. I so much prefer face-to-face and audience interaction. But anyway, I guess this is the best that we can do in these current times. So Dr. Neeta, once again, thank you for having me on this panel. You had requested that I discuss price in particular in detail, because that is what probably will be the front line of physical therapy management that a hematologist might have to do during the OP clinic. This was what you had shared with me about this session, and that's exactly what I've done. I'm talking to you from the hospital, from the main physio treatment room. I have one patient with me on whom I can demonstrate some of those simple techniques of icing or crepe bandaging as the questions and depending on the time that is available. So this set of presentation slides are endorsed by World Federation because I was privileged to be part of the group which created the online curriculum for MSK treatment, treatment of MSK bleeds. So there is a set of references at the end of it, which anyone who's interested can use for further reading. So first of all, whenever there is an acute joint bleed, replacement therapy is the most important. That is something we all accept. But in India, the situation is not ideal. And often there is a situation where replacement therapy is limited. So many a time one comes across a situation where the patient and sometimes the treating physician is more focused on getting factor for that joint bleed, when simple physical therapy measures can actually reduce the bleed, the severity of the bleed, can reduce the sequelae of the bleed even much before you administer factor. So these are some simple things that one can do right in the beginning when there is a bleed to reduce the incidence of long-term joint damage in these bleeding patients. Okay. Now, all acute bleeds are painful. So once again, I reiterate what I just said, that both parents and patients will be very anxious about the bleed. And so it takes time to convince them, develop a relationship so that they get used to not always focusing on factor on demand for these bleeds. So I'm just going to discuss mainly the first line of treatment, which is RICE, which is rest, ice, compression, and elevation. That's a popular acronym. So by rest, we mean immobilization. So we're not going to allow that particular limb in which there is a bleed to move. And rest primarily means no weight bearing on that particular limb. Because the one thing which is well established is loading a limb in which there is a bleeding joint will worsen the effect of that bleed on that joint in the short, in the medium, and the long term. So it's important not to weight bear. Then, of course, we'll discuss ice. We'll talk a little bit about compression, elevation, and on to exercise and functional recovery. In early physical therapy treatment of acute bleeds, What is not indicated is the right-away use of any kind of modalities, electrophysical or electromagnetic energy related modalities, as well as orthotics. They're not indicated right away. The orthotics are not indicated because patients often will not tolerate these orthotics. The joint is swollen, there's a lot of periarticular muscle spasm, there is less movement, a lot of anxiety. In that, if you try and fit an orthotic, it's only going to worsen the situation, not get it better. And most physical therapy, electromagnetic and electrophysical modalities are about increasing circulation. So here we have had a bleed and we are trying to arrest that. So that dictum kind of goes the opposite way. So usually we don't use these machines. So this is a general rule of thumb that we play by. So when do we rest the joint? So even if you don't prescribe rest, obviously a child or an adult with an acute bleed is not going to move. So it's basically as soon as it is identified really by the patient that, you know, there is pain, swelling, redness, difficulty in movement, they're not going to move. So rest for the acute joint bleed starts right, musculoskeletal bleed really starts right from that time. And why are we resting it? Because we do not want the clot to be disrupted. We do not want the joint to rebleed, and we want to promote healing. It is also because by not moving, there is more comfort, because whenever you move, your muscles around the joint will move, and therefore the pain levels in the patient will increase. Okay. What do we mean by rest? So by rest, we mean not always total body rest. Total body rest, we mostly use when there is usually a muscle bleed in the core of the body. The most common one being an iliopsoas bleed, for example, which happens in the pelvic core. And there, yes, you need to somewhat, go on to sort of complete body rest and let the person be in recumbent position. But usually by rest, what we mean is minimizing movement and reducing the weight bearing on that particular injured part or limb. So we want to quieten down activities. And sometimes once the swelling is slightly reduced, by this clinically what I mean is usually when there's severe swelling, there will be a lot of glazing of the skin. The skin will have a shiny appearance. There will be this like it will have balloon-like appearance, the synovial joint. So you want that to reduce, and you can see some creases coming back in the skin, some middle range movement, a little bit. The child may not cry, be a bit more comfortable. At that point, maybe you can begin to support the joint with a splint. Also, we mean activity modification by rest. So you want to support the bleeding joint during activities. You want to modify those activities. For example, you may say you can walk up to the toilet, but you cannot, walk around more. You cannot play. You cannot go to school, for example. So that advice is called activity modification. Obviously, as I've already said, it means no weight bearing, and it also means the prescription of an appropriate walking aid or which may be a crutch, it may be a walker or a wheelchair, depending on the bleed, the ability of the patient, the pre-morbid status of the patient, and their immediate environment. Now, for upper limb bleeds, obviously, as a small child, it'll be nice to restrict their space. So there is one principle which we've adopted from veterinary medicine, where you cannot restrict an animal like a dog who has a pelvic fracture, for example. You cannot make them go on complete rest. So vets often use an immobilizer. So in some small babies and small children who come to me, for example, and some of my colleagues across the world, we tell them, put them in a crib so that at least they're not moving that much. And that helps give them some rest. And obviously, we don't want for upper limb bleeds also weight bearing, like putting weight on the arm of the chair and getting up. Crawling should be discouraged, and they should not be lifting objects, etc. So how long should we rest? This is a very common question asked by everyone. Ultimately, I think the patient should listen to their body. So you should rest as long as your limb feels comfortable. So the 4 main signs of a joint bleed, which is swelling, redness, pain, and restriction of range, should begin to improve. Then you can say, okay, maybe allow more activity. Now we know by recent literature in wound healing and formation and resorption of a clot in the joint that this can take up to 4 to 7 days to happen in an acute joint bleed. So certainly rest and restricting weight bearing should happen for 4 to 7 days if you want to preserve the joint, the chief tissues in the joint, the synovium, the cartilage, and the subchondral bone in the long terms. We want to remain invested in these tissues. We should be strictly resting them, especially after virgin bleeds, not bleed on bleed. Obviously, those are different clinical entities. But these first joint bleeds that happen, we should be very strict and very conservative about when to start movement and active physical therapy. Of course, it is not so easy to get patient compliance in hemophilia for so many reasons. We also, at the same time, will start little exercises as soon as some movement occurs, as soon as the swelling begins to reduce. There isn't that much warmth. Warmth comes down, and we only check warmth with the dorsum of a hand, the old clinical way. That's the simplest way, but it's pretty accurate when you keep doing it over the years. So you can make out, okay, the warmth has come down quite a bit. Now they can start doing some simple static or isometric exercises, for example. Pain relief is important. Often, for some reason, even to this day, patients come to me for physical therapy from lots of places in the city, outside the city, state, and even the country. Many times the pain relief is not being attended to by the physician or the hematologist sometimes. And the patients just bear with this pain. So remember, when a patient whose joint has a bleed is in pain, especially acute pain, there's going to be lots of muscle spasm. This muscle is not going to work properly. The muscle's biochemistry is going to be deranged. The muscle is likely to remain contracted, and by remaining contracted, it will weaken neurophysiologically. So it's important to prescribe some form of pain relief for these patients. Simple pain relief like paracetamol will help to keep their pain down. And of course, their pain comes down as long as they get factor access quickly. Icing is again very, very important. And the chief way icing actually works is by numbing the nociceptors in the joint. And mainly icing reduces the speed of signal transmission by the nociceptors, and thereby the muscle relaxes, and so there is pain relief. Ice does not actually stop or recede bleeding in the joint, as is a common notion. So muscle bleeds can be deep, hidden, and very, very painful. And especially if the muscle is stretched or activated. So one should be extra cautious about deep muscle bleeds, which will only show up a few days after these symptoms. Okay, now how do we immobilize? There are a number of ways. A simple thing is a resting splint or a back slab. You can also use something called a tri-panel knee brace. If you have time, I'll show you one or two of these splints later in the session. Number of materials are used to make these splints as well. And what is the position that you splint them in? You put them in a position of comfort. So usually that is a joint in mild flexion. For example, the knee or the ankle, it's slight flexion, that's all. You don't impose a position on the patient. Listen to the patient, get the patient in a position in which they are comfortable and they're likely to be able to hold that position for some time, where intra-articular pressure is minimal, and it will allow for healing. Now, how long do we immobilize? Immobilization ideally is supposed to be until bleeding stops. So how do we check this? Usually we check this clinically. So we give factor, we start off on all this, and then as all the signs come down, we assume bleeding is reducing. But as I said, for first bleeds, it will be good to wait for 4 to 7 days before we start any aggressive physiotherapy or movement or full function. Now, usually the middle range of a joint will get re-established. I'm not sure if you can you see me? Can you see my elbow? Hello?
Yes, we can see.
You can see. So this is the middle range. So this is the inner range and this is the outer range. So you can actually find that as the joint bleed gets better, it is this middle range which will get re-established. Okay? But you need the full range. So it'll be good if at least 80% of this range is fully established before you call it quits with immobilization. What is important is not to give them a brace. For example, sometimes people are using braces and elastocrate bandages just like that all the time. And constantly bandaging that will not allow the muscle to function, and the muscle will atrophy. The joint will get stiff because it can't move properly. And that has its own long-term musculoskeletal complications. So eyes, I just quickly covered. And how do we apply ice? The most common and easiest way is crushing ice, putting it in a damp towel, making a little pack, and applying it gently, like a fermentation. So you sort of dab it gently over the joint. That is something which is tolerated. What should not be done is putting ice and sort of just dumping it on top of the joint, whether it's the anterior surface or the posterior surface, and leaving it for a very, very long time. Cold water in a bag with ice, with bits of ice in it, has a very nice effect. And there is a machine called the cryo cuff, which I have mentioned here, and I can show you that as well, which is very useful in clinic settings and hospitals to apply cryo uniformly around the joint and the limb. There are gel packs. There are some other methods of icing available as well. But in my personal experience, they don't seem to cool beyond the skin. Not like when you use ice or if you use cryo, which is indicated here. However, gel packs are very easy to use. Like, you can carry it in your bag. It won't get your bag soggy. You can go to office, put it in the fridge, take it out and use. So there are advantages and disadvantages of all these various methods of applying ice, depending on the situation. So these tips from the field are just my own points from what I've seen and observed. So patient preference is important because ultimately the patient does not like ice. Some of them don't. They won't tolerate the ice, then they won't use it at all. So they prefer gel pack, then let them use the gel pack. Something is better than nothing. And obviously in some cases, some patients, especially, we are talking acute bleeds, and we are compartmentalizing things because it's easier for us to understand them. But in a clinical patient, as you know, you will see everything. So you'll have one acute bleed. There will be a proximal joint, which will be in a different state of affairs. So there, maybe the patient will not like ice, and they often don't want to use ice. They feel the pain is worse. In which case, I think it is important to take their opinion into consideration and keep the treatment patient-centric. Then looking at compression. So why do we compress? Basically, with the external pressure, we limit the distension that is there in the joint bleed. It will decrease the ooze which is there in muscle bleeds, and it helps achieve a tamponade effect more quickly. It also apparently allows quicker resolution because the volume of blood in the joint or muscle doesn't build up as much as in the case when you don't compress. But compression is a little bit of a tricky thing. Sometimes you can't compress. As I said, when there's a severe swelling, it makes no sense to compress and the patient won't tolerate it. The other thing is sometimes there are the odd patients, who will listen to the medical professional and compress against the way they're feeling. Some of them land up with compartment syndromes. So compression has to be assessed a little more carefully on an individual basis, and it's difficult to be blanket about advice about compression, I find. And how long do we compress? Again, till we've got the desired result of swelling and bleeding reducing. So that's what I said. You have to be cautious about compression and whether it affects circulation or causes some form of neurovascular compromise. Sometimes you still see all this. The one thing I forgot to mention in casting also is not to put full cylindrical cast. It's a common problem from government hospitals, for example. They put a full cylindrical cast and you land up with lots of problems. So the compression, if there is pain is increasing, obviously you need to remove the compression right away. And as I've already mentioned, long-term use of compression bandage without any check on it will cause muscle atrophy. So finally, what it all comes to is the physical therapy schedule also should be prescribed to the patient. It's not, I feel, as easy as us just saying, giving a leaflet out and say, okay, follow RISE. It is really not so easy. There are so many nuances to it. And if we pay attention to it, you get very good results using that as a first line of treatment. Okay, so this is about elevation. Elevation basically supposedly decreases your intravessel pressure and limits the ooze. How do you do it? You elevate the limb above the level of the heart until the bleeding stops. Sometimes you need to use elevation, not always. There are rare instances where people have had multiple bleeds and they come with the whole lower limb really swollen, too much immobilization. But usually in a routine singular joint bleed, young child first bleed, you don't usually need to see elevation because you don't find the whole limb being swollen. So this is what I had mentioned to you about the modalities and how applying energy is not indicated in acute bleeding. Then a point about exercising. When do you exercise? So as I said, isometric exercises, which involves basically exercising the muscle without moving the joint that the muscle controls. That usually can start within the first 1 or 2 days. And that is terribly important because it helps keep the muscle bulk and prevents wasting, particularly of muscles like the quadriceps, which are fast twitch fibers and dominant, and they waste at a crazy rate. So you lose 24% of muscle bulk in 3 days of your quadriceps. So months of physiotherapy, months of exercise, all gone to pot because of one joint bleed. So the static quadriceps really helps when done properly, will help prevent that from happening. And by doing all this, what are you doing? You're investing in the musculoskeletal health. So there is the sequelae of that particular bleed is limited, and therefore long-term frequency of joint bleed also will come down. Okay.
Can we take the demo?
Or shall we wind up? Because I've covered your main points.
So we'll take up the demonstration towards the end based on time.
Sure. So I think I'll stop here. This is all about exercising, and these are a few additional resources and references that I've added at the end of the presentation. So thank you so much for this opportunity.
Thank you. When I heard Dr. Pamela first, she mentioned in one of her earlier talks that hemophilia changes from a hematologist disease to a musculoskeletal disease as the patient goes. That's like really true. And we have to revise our musculoskeletal knowledge, anatomy when we are start seeing patients, because, and like you said very rightly, prescription, you need to give a prescription for all this in your paper. Otherwise, they're never going to listen to you.
Yes. Thank you.
With those take-home messages, I'm going to the next part of the discussion, which is the case discussion. So we have 5 cases. We'll take it up as depending on availability of time. Can you see my slides?
Yeah.
Okay, so case 1, Dr. Ravi from our center will be presenting the case.
So first case is a 9-month-old male infant. He was the only child born of non-consanguineous marriage. He presented with complaints of recurrent ecchymosis over the lower limbs. He had a positive family history of hemophilia present in the maternal uncle. He was evaluated for the same. The HB was 10.6, TLC 16,000, platelet 4.1 lakhs, PT was 12.6 seconds, APTT was raised 71.5 seconds, and factor 8 level was less than 1%. So a diagnosis of severe hemophilia A was made based on the bleeding profile. Initially, he had ecchymosis. He had a first joint bleed at the age of 1 year. At that time, he was advised prophylaxis, but could not be started due to the COVID-related constraints. A second joint bleeds happened at 1.5 years, and then he was started on prophylaxis. Since then, he is on factor 8 prophylaxis, 250 units once a week, which is 20 units per kg per week. So this case is presented to see a newly diagnosed severe hemophilia A patient.
We're going to take up cases based on their degree of complication. So this is like a fresh patient with hemophilia A. A family, despite having a family history, is quite anxious. So Tulika ma'am, to start with you, how would you, so these are the sites of bleeding. We're not going to go to the very basic parts of hemophilia because I think most of us are already aware of it. So Tulika ma'am, how would you counsel a new family? They have so many questions usually. So how do you usually deal with them?
So most importantly, don't try to counsel everything in one session. You will have to explain to them that this is a lifelong disease and injury prevention is really, really important and this is their responsibility. A lot of times families get very sad about this, but I often tell them that, you and I don't get hurt as we grow up, but if you take care of the child when they're small, then they will not have any disability or any permanent sequelae. As you can see, you have to explain about the bleeding episodes, keeping a bleeding diary, all the medicines to avoid, like NSAIDs and other things. How to give the vaccines is to be explained, and often we have a small handout that is given to the pediatrician to convince them, because sometimes pediatricians feel that if they don't give the vaccine in deep intramuscular, then the antigen will not act and they won't get antibodies. So all of those things are really important. You don't necessarily need to talk about schooling and all at the first visit, but make sure that they stay with you, and at different stages of life, you will need to keep reinforcing this.
Yes, ma'am. So, and a lot of patients are at the first visit itself, they are talking about curative therapy. So we have to kind of slowly take them through the process and tell them not to kind of aim for curative therapy will come during their life, this lifespan, but definitely aim on what is currently with us. So Dr. Uday, how do we manage? This is like the basic bread and butter of hemophilia management, which is the management of an acute bleed. What is the product that you would use? What is your logic in using it? What is the dose and what is the duration of factor support?
So good afternoon to all. Good afternoon to all. So the most important thing for the students would be, the answer remains to be that we need to give them factors. But the concept remains, which factor, how much, and why should we give that much of factors to these individuals? Because you would find different nomograms available across different textbooks. So to understand, in pharmacokinetics, when we give factor to an individual, there are two aspects. One is a peak dose effect and second is area under curve. So as soon as we give an infusion to a child, the factor concentrations in the body, they rise up immediately somewhere between 80 to 100%. Now, as the time goes with the passing hours, the concentrations keep coming down. And after the first 12 hours, the thing is, it is the area under curve, which basically helps the patient. And lastly, there will be some residual amount of factors which will be there after 24 hours. So if we go to the next slide, please. Yeah. So the previous one. The previous slide, please.
This one?
Yeah. So if we look at the one in between, yes. So if we look at the next one, the next. Yeah, this is one. Okay. So the peak dose effect is mainly important for activity related bleeds, whereas the area under curve is important for asymptomatic bleeds. And the trough levels that we are talking about, the last 1%, they are important for preventing spontaneous breakthrough bleeds. So when a child gets injured, a hemophilic child, so the most important thing is to prevent a activity related bleed. So we need to maintain high concentrations. Thereafter, once the clot stabilizes, we want to prevent the asymptomatic bleeds, wherein the area under curve mechanism works. And when we talk of prophylaxis to these children, our concept is to prevent the breakthrough bleeds. So that's why we talk of maintaining this 1% to 2% of the concentrations. So yeah, continue with the slides. So once we have discussed about the concentration of the factors, the next thing is about the type of factors that we need to give. That totally depends upon the safety, the purity, and the efficacy of the factors. So when we look at the safety of the factors, once the plasma was discovered in year 1950, thereafter, slowly different combinations have come up to look at the safety or to purify the factor further and further. So the next slide, please. So whenever a factor is prepared, there are 3 or 4 things which take place. First, we culture the factor, all the recombinant factors, then they are purified, then they are formulated with a stabilizing agent, and a final product is prepared. So the whole concept of first generation, second generation, and the third generation factors is, if the animal or human derived product proteins are present in the cell culture and are used for stabilizing the product, it's known as first generation product. If the animal and human derived proteins are present only in the cell culture, but for stabilizing we are using sucrose, non-human or animal derived proteins, it's called as second generation. And in the third generation or fourth generation, we don't have animal or human derived proteins at all. So by this technique, we are trying to minimize the contamination by the animal and human derived proteins. So the various protein related diseases in the form of the viral illnesses, the retroviral infections, and the parvoviral infections, herpes, adeno, and also the prion diseases, we try to minimize as we keep increasing the generation. So the days have gone wherein we started using plasma, then FFPs, then cryocrystates. Now we are talking about the CFCs, so or the recombinant factors, because of decreased chances of contamination. So these are the various viruses which are tried to be minimized. So the most important concept is the solvent or the detergent based purification and the heat based, which takes care of the enveloped and the non-enveloped viruses. Whereas as of now, we don't have a technique to take care of the prion diseases. So that still remains to be a risk. As the days come, we presume with the further generations of the factors, even that would be taken care of. So these are the various techniques: detergent inactivation, immunoaffinity chromatography, anion exchange, double nanofiltration, gel filtration. So based on all these techniques, the particular product is made to be potentially free from all these viruses that we have spoken about, the enveloped and the non-enveloped viruses. Now, lastly, as far as the dosing is concerned, because every unit of factor 8 increases the level by 2%, therefore, for the child's weight, the body weight into the factors required divided by 2 is what is the factor 8 requirement, whereas factor 9 we just take as much as the body weight. And the amount of rise that we require, because we presume that every hemophiliac has 0%, and what we presume is that for depending upon whether we want to prevent asymptomatic, symptomatic, or activity related bleed, we rise the levels by so much. So there are nomograms which we are going to show in the next few slides. So these are the various nomograms, and as per the latest nomograms, we have something as a lower dose practice or the higher dose practice, and the percentage, the peak dose that you are aiming at differs in these two different types of practices. The lower dose practices are generally practiced in the low socio-economic countries, whereas higher dose are those where either the child is involved in heavy sports or in resource non-constrained settings. We use higher dose practice patterns. So we aim at this, and these are the levels that are required for different types of bleeds.
One more thing on continuous infusion. Like there are a lot of questions usually that come up that in order to save factors, can we give it as a continuous infusion? What is your opinion, Dr. Uday?
Continuous infusion theoretically sounds very good for decreasing the bleed, because we are going to use only area under curve mechanisms. Therefore, we are preventing all types of asymptomatic and spontaneous breakthroughs. But the challenge remains to be that the viability of the factor at room temperature is a major limiting factor. Now, with the extended half-life products or with the various types of the adjuvants that we are using, that is pegylation, or by using the Fc gamma receptor, So by that, the whole technique is to make sure that they are available for a longer period. So they are a far synergistic or a synquinon for a continuous infusion. But the currently available factors, they are not viable at a room temperature for a very prolonged duration.
Yes. So that has to be kept in mind before going for that. So Tulika ma'am, so this is a new family. So one of their usual questions, especially educated parents would ask us, is about, should I put my child on prophylaxis or shall I continue with episodic treatment? So how do you advise? And when you start prophylaxis, how do you start it? How do you initiate prophylaxis in a new patient?
So with the current body of evidence that we have, we know that on-demand therapy will not prevent joint destruction, because you're giving it after a bleed and then you have multiple bleeds and the joint gets destroyed. So the only standard of care is prophylaxis or replacement therapy. The ideal way of giving it is to give it before the second bleed. Usually after the first bleed means that it's, I think, there because many times for families who don't have a diagnosis or a family history, that's when the child prevents. And ideally, prophylaxis should start before the age of 3 years in order to ensure that in the future these children have good joints. Most of my patients, because we are at a government hospital, are not on the ideal primary prophylaxis. I think the case you illustrated was very well managed. And we also start similarly with initially once a week and then increase to twice a week, or finally go up to the 3 times a week, because in a very small child, venous access is an issue and this is an IV preparation. um, uh, and earlier when people used to put in porta cats and central lines, they actually found that doing this was harmful because many patients developed inhibitors. And for these very small children that you're starting, or if the parents and everybody are watching, they may not have so many bleeds. So I think this is the best way to do it. The new thing that has come up, and I think COVID is making us think and use things in a different way. So emicizumab, which is a non-factor product, which I think you're going to talk about later, it's actually something that we have used a lot because this is an injection that can be given once every 2 weeks and it is subcutaneous and there is no risk of developing inhibitors. So we've actually had many families where we've given this injection, and in very small children, we've actually even given it once a month. And this is a new way of looking at things. And I think in India, we often, because of cost, are forced to be very creative. And in fact, even the WFH has said that for small young children, emicizumab can be used for prophylaxis. So what we're doing is not really totally out of the box, but I think it's very important in COVID times because we don't want the families to have to come to the hospital very frequently for injections.
Yes, ma'am. So one thing I wanted to ask you is, like, when we have, this is about joint bleeds, but suppose if a child is presenting with an intracranial bleed at say 2 months or 3 months of age, would you start prophylaxis from then on?
Absolutely. I think once you've had an intracranial bleed, this is very serious. And these would be patients that I would want to put on prophylaxis. And I forgot to mention extended half-life products. So those are actually available to us from the World Federation of Hemophilia as a humanitarian aid. And these can also be given, and they will also reduce the number of injections that the child needs, even though the factor 8 extended half-life is not as long acting as the factor 9, which can be given once in 10 days or 2 weeks, but at least you can have maybe once a week dosing or twice a week dosing for small children. So this is another important thing because you can give less injections and get the same coverage.
Yes, ma'am. Thank you. So Dr. Pamela, just quickly, could you recap what you said earlier, that in this baby with a joint bleed, how would you immobilize and when would you start physiotherapy? I don't think we have time for demo right now, ma'am. We'll see the demo towards the end if we have time. So if you could quickly tell us again, because that's so important for management going ahead.
Now, again, as Dr. Tulika said, I think you need more than one session of counseling with these patients about how to manage the musculoskeletal bleed, focusing on all the various points that I've discussed in the presentation, right from icing resting, as I've said, in a baby using an immobile, like a crib, for example, where the baby is in one place. The one point I'd like to make is many parents want to use padding. They like to use padding. They sometimes make their own pads. I discourage them from doing that. I think watching over the baby, making sure the environment is safe and secure. Obviously, you don't want a sharp object or anything which is high risk around. But padding should be discouraged, because padding will land up with long term, the baby's skin, the baby's proprioception will get affected, and the baby will be then more prone to problems, because at some point you cannot pad. So I discourage padding, but there may be a difference of opinion there. So I think it's more about handling the baby right, using the rice appropriately, and creating a safe environment for the baby to reduce risks.
Many families use what is called helmet caps. So before, when they take the babies to the park, so that probably, if it's made of cloth, it should not harm.
Yes.
At least if they're
But discourage any hard helmet. Sometimes they do all this thermocol, they get them made. They use what is available for baseball and other games, things like that, which I usually discourage. In fact, right now on follow-up, I have 4 little babies, like 2, 6 months, 9 months. Very interesting. And the more normal we treat them, the better they seem to be doing. None of them are on prophylaxis. The only one more point that I would like to say is using hydrotherapy with the babies. Very easy to do in the house with a bathtub. And hydro makes such a difference to the joints and its development and the proprioception angle. Very, very useful. I'd strongly encourage it. And typically, very people are worried about the babies falling sick from virals and fevers. But I always say, if you use warm water, which is comfortable, close the bathroom door, close the windows, don't have a draft, dry the baby properly after the bathing or the playing session. Babies stay quite well and fit. So hydro is something I'd encourage.
Okay, ma'am. Thank you. So next question, ma'am, to Dr. Srimati, ma'am. So this is a child who has come in with a diagnosis, and we have done one test which has shown a factor rate level of 1%. Would you advise repeating it sometime later, and both for confirming diagnosis, and would you advise, like I've seen centers that do testing for monitoring therapy as well. So what is your take on it? And second is, when would you advise genetic testing in babies? Do all babies, do you advise genetic testing, or only in select few?
Yeah, the first question on the repeat diagnosis, as I mentioned in my talk, only the vitamin K depends. If the child is less than 6 months old, we repeat the tests after 6 months of age for all vitamin K dependent factors, because we know that it's not the basal level what we see in the child. But in case of, if it is factor 8, we never repeat for a confirmed diagnosis. As long as you're sure that your sample is appropriate, you don't have to repeat it at all. That's the second question on the genetic diagnosis. We don't do genetic diagnosis in all the cases. See, the application of genetic diagnosis is in carrier detection and prenatal diagnosis. So what we do is, as soon as we see a new case of hemophilia, we counsel the family. There is a very extensive genetic counseling for the family for the next pregnancy, or for all the female relatives of the patient to come for carrier diagnosis before they get married. But otherwise, here and there now, because prophylaxis, ITI, all these procedures are going on, because we know that the null mutations have a very poor outcome in prophylaxis and ITI. So here and there, we get requests for genetic diagnosis. The other reason what we get requests for genetic diagnosis is when we get a new case, whether the mother is a carrier or not, because we want to know whether the child is a de novo, total de novo case where the mother is not a carrier. This will help for the subsequent pregnancy diagnosis, whether she has to come for PND or not. But otherwise, when we diagnose a new case of hemophilia, because as it is, probably it depends on the workload, there's too much of workload, and I don't see any reason why we should be going for a mutation detection at that point of time when we have a confirmed diagnosis.
Okay, ma'am. Thank you. And what about monitoring, post-infusion monitoring?
Post-infusion monitoring, we do only when there is no satisfactory clinical response as we expect. Otherwise, we don't do a factor level every patient when we give the factor 8 or factor 9.
Yes, ma'am. So that was about a new child who's just been diagnosed. Coming to the second case, Dr. Ravi.
Our second case is an 8-year-old boy who is a known case of severe hemophilia A. He was diagnosed at 1 year of age. He presented with recurrent bleeding in left ankle since 3 to 4 years. Target joint were bilateral knees, left ankle, and right wrist. His annualized bleed rate is 24 and annualized joint bleed rate was 80. On examination, in the left ankle, there was tenderness and restriction of the movements, along with the fixed deformity of the left ankle joint. The temperature of the involved joint was raised, and the child was unable to dorsiflex the left ankle joint and had a limping gait. He was started on twice weekly tertiary prophylaxis at 15 to 20 units per kg per dose and a gradual physiotherapy. He was later switched to extended half-life factor 8 since last 2 months. He has recovered partially with ability to dorsiflex the left ankle and improvement in the limping. This case has been presented to demonstrate the high bleed rate, target joints with deformity, and minimal access to prophylaxis, which is mostly the case in our patients.
So, mostly, like, although we advise prophylaxis for most of our patients, we don't get access to prophylaxis. Such patients, like the patients who are like 8 to 15 years of age that do come to clinics, many of them have already the joint damage that has already set in despite our best efforts. So I'm just skipping these slides. This is how the joint damage evolves. These are very, very good review articles on that, how the synovium thickens and then slowly the cartilage and the bone starts getting deformed. So Dr. Uday, one of the common problems, like suppose this 8-year-old boy with multiple target joints is coming and telling me that there is pain in the joint. The joint is already swollen and there is already restriction of movement. So how would you differentiate between an acute bleed versus a chronic arthropathy that has already been there in the joint? Dr. Uday?
Now, this is a clinical nightmare. Yeah, this is a clinical nightmare for most of the clinicians, because when you get a call at night 8 o'clock saying that I have a swelling in the leg, you really can't make out. So there are two important aspects. First, the most important thing is to listen to the patient, because most of the patients or the parents, they are so clued up, they have an aura before a bleed, and they generally are able to tell you that they are going to develop a bleed. But despite that, there will be 15-20% times where you will not be able to make out a difference until unless you have some imaging modalities in the form of ultrasound in the emergency or something. But a very easy way is to give these patients one dose of factors, and if there is a rapid resolution of pain following the infusion of the factor concentrate, it's highly suggestive of acute hemarthrosis. Whereas if the pain, which is generally because of a synovitis or a arthropathy, so it improves after the activity is taking place. So with activity, the pain improves. So that is suggestive of a synovitis or an arthropathy. But as I said, other than the ultrasound, there are not many methods in the emergency room to differentiate. So if you look at this Venn diagram, there is a huge overlap between hemarthrosis and hemophilic arthropathy. Most of the symptoms are the same. Particularly if a patient has got crepitus or a muscle atrophy, and if there is locking, you can go that these features are most probably suggestive of arthropathy. But one thing which most of the students need to understand is even a patient who is having an arthropathy can also have on the top of it a bleed. So these are known as target joints, where the arthropathic joint is more prone for bleeding when compared to a normal joint. So in those situations, the scenario really becomes vicious.
Yes, sir. Thank you. So you mentioned ultrasound. So Dr. Pamela, could you quickly tell us what are the imaging modalities that are available, and would you advise any of these in a routine practice? Ma'am, I think you're muted.
So we do imaging studies in patients with hemophilia, mostly for assessment, to do screening, Sometimes to get a visual record of what's going on, if you have the luxury of following a patient up for many years, it's very useful. And also sometimes to direct treatment. Simple example is someone who's, say, an adult with advanced arthropathy. You may do an X-ray, a simple X-ray, and if it shows complete obliteration of joint space and a very degenerated joint, you might advise them for joint arthroplasty. So that is one example. Now, of all of this, really X-ray is the most common, easily accessible and cheapest form of investigation that is available to us. But X-ray will only document bony change. So apart from X-ray, ultrasound is often used. For example, in muscle bleeds, in iliopsoas, you want to see how big the bleed is. Sometimes if someone has come with a chronic iliopsoas bleed, you want to see if it's a pseudotumor and what sort of state the bleed is in. Is there a lot of loose blood, or is it more thicker blood which is getting organized and becoming the muscle is getting fibrous? For that, CT is much more useful because chronic change is easily imaged in a CT. On MRI also you can use it, and technically an MRI is a 99% tissue specific test. It will show you synovium, ligaments, cartilage, but MRI requires expertise to interpret. It is very expensive, and particularly blood to make out the differences in MRI requires radiological expertise to pick up more than when you see a CT. What is a new trend is what is called point of care ultrasound, as Dr. Uday already mentioned. Very useful if we are trained in musculoskeletal ultrasound, where you can immediately image the joint when you see it and decide, okay, this is a bleed, and so this requires factor, and that will certainly help us use our resources more effectively.
Yes, thank you, ma'am. So, Tulika ma'am, Ravi mentioned annual bleed rate. So could you tell us like how do you monitor patients? How do you assess response to treatment, and how do you quantify bleeds in hemophilia patients? Ma'am, please unmute, ma'am.
Recommend the patients keep a diary. I hope I'm audible. And the ABR is basically the annualized bleed rate, which is calculated by the number of bleeds that are reported by the patient divided by the number of months and then multiplied by 12. So you get to know exactly how many bleeds you're having. A better record is actually the spontaneous ABR, because this tells you ABR can also increase if you have a very active child. So children who are very energetic may have a higher bleed rate, but the spontaneous ABR is usually required for patients who are on prophylaxis, and any spontaneous bleeds that are happening there are important and will tell you how good the therapy is happening. The ABJR, the annualized joint bleeding rate, that basically tells you the number of joint bleeds that are happening in a year. And of course, this is affected by if you have any target joints or obesity and other things. So these are the markers that give you a rough idea. And of course, it's important now, the WFH says that each time you treat a bleed, you need to assess the response to the bleed. And this is important because now we have many products, and some patients may respond not so well to certain products, or they may have a bleed that is not responding well. So we need to be aware of all of these things. But I think what is more important and what we are not doing in India is what Dr. Pamela is going to discuss about. And those are the what really tells you the structure and the function of the joints.
So this is from the WFH guideline again. So there are many ways of assessing the damage which is there, but ultimately it boils down to how active the patient is and what the patient can do. So there are multiple scores which are available for that. And for the joint assessment also, there are scoring systems. So periodically, it will help us over time, help us assess how bad the joint is becoming. And then there are quality of life, like in any chronic disease, there are quality of life scores as well. So Dr. Pamela, could you briefly tell us as to how hemophilia joint health score is calculated? I know it is a very big topic, but just salient points, ma'am. Please unmute. Ma'am, you are muted.
Okay, so that would take us a long while. It is not enough time. Basically, what you have to remember is the HJHS is basically an assessment of joint structure, not of joint function. First point. Second point, please remember the HJHS can be used only in patients of ages 4 up to 17, not beyond, not below. This is a very important point to keep in mind. In fact, we ran a seminar, a talk in the meeting in Madrid last year, and we discussed the same thing about the HJHS. For various reasons, it's become very popular and people are just using it randomly in all age groups, and it is not useful for that. And then you'll end up misinterpreting your subjects. So this is a very, very important point. Second thing is, it basically was created by a group of physiotherapists who are part of the International Prophylaxis Study Group based out of Canada. So if you imagine Canada is a developed country, and so for them resource constraint does not exist. In fact, all their children are on prophylaxis from the beginning. Canada is one of the sort of best levels of treatment, I think. So they are seeing patients with very, very minor or almost non-existent joint disease. So these scores and these signs that you see have been made on that subject population. Take that and put that in India, where it is being very vociferously and very commonly used everywhere, and you'll end up with lots of blocks. Okay, this scoring will not work for many, many reasons, because our children are not very rare for them to, have prophylaxis right from time of diagnosis or after the first joint bleed. So they'll all have some changes or the other. Then this becomes extremely confounding. So just one example that I'll give you, if you can just keep it there, it keeps moving, that's why.
Yeah. This slide or the...
Yeah, this time. Yeah, this or the previous one. You can keep it there. I'm only going to point out one thing and then move on, just to tell you to use it with caution and patience. So, for example, you have joint pain. Now, if you see, joints pain is scored 0, 1, 2. So, no pain through active range of motion, no pain through active range, only pain on overpressure and palpation, pain through active range. So where is resting pain? There is no score for resting pain. So we don't know what to score it. Now, when I tried to use it, I came across all these problems. So when do we see resting pain? We have been discussing acute bleeds and rest. When you see acute bleeds, you'll see rest. How do you score that? Okay. Then you have problems with their measures of flexion and extension as well. And this is very confounding when you use it on synovitis, particularly chronic synovitis. It just won't fit. You can't score it properly. Okay. You also cannot really, for example, it says duration of swelling. No swelling is, and 0 is no swelling, or if swelling is less than 6 months, and 1 is greater than 6 months. So you land up with no swelling for a burnt out joint, for example, which has gone through acute bleeds, acute chronic synovitis, arthropathy. Arthropathy will get 0 here, and you will get a falsely good score as if the joint is healthy. So like that, there are many issues. There's no time for that, so I'm going to stop. But I mean, that's all I have to comment on HED. So use it, but use it with caution for the correct age group and for mild joint disease.
4 to 17 years, like you said, I did not know. Thank you. So coming quickly to extended half-life products, ma'am, now that you said that there are products which are going to, they are already there in India, available to many centers, and some of them are coming to our markets. So what are these products essentially, and how does the dosing differ when you use it for bleeds? Ma'am, you're muted.
The extended half-life products are made by various different methods. They can be linked to different proteins like albumin, polyethylene glycol, that's pegylation. Basically, all of these work on the physiology of decreasing the elimination of these products, because we already know that even in normal factor VIII, the half-life depends on the von Willebrand factor that is available in the body. So these are some techniques they've done to extend factor VIII and factor IX products. The factor IX products have been extended to a longer duration. So most of the extended half-life factor IX products can be dosed every 10 days to 2 weeks, while the factor VIII products, the half-life has been increased to about 1.5 times. And so the dosing is given every third day rather than every second day, as we usually give for other factor VIII products. The dose, we have one product that we often get through the WFH, it's called Eloctate. And that product we actually dose 50 to 65 units per kg. And we've often actually given it as prophylaxis once a week, or in some very young children twice a week. It's interesting to note that younger children often have a shorter half-life, and that's why they actually many times may require more frequent dosing, even of the extended half-life products compared to older children or adults.
Thank you, ma'am. So that's, ma'am just said that prophylaxis also you started 1 to 2 times in a week and slowly take it up. So coming to the third case, Dr. Ravi.
Our third case is a 14-year-old boy who is a known case of severe hemophilia B. He had episodic treatment till 2019 with annualized bleeding rate of 6 to 8. He had right psoas bleeding in 2019 December. There was pain in the right thigh of 2 days duration, for which he presented to us, that was associated with limping gait. He also gave history of paresthesia of the medial aspect of the right thigh. On examination, he had a right hip which was flexed and it was painful on extension. There was swelling and tenderness present on the right lumbar area. Based on the clinical findings, right psoas bleeding was suspected and he was started on factor IX at the rate 30% replacement dose for 5 days. He was advised strict bed rest along with the supportive care. He improved and was able to walk in 2 weeks' time. 3 months later, he had rebleeding, which was in the month of March 20. He was unable to extend the right hip and right knee joint, and there was paresthesia of the medial aspect of the right thigh. He was started on treatment and continued on secondary prophylaxis. He was again advised strict bed rest. He is on regular follow-up, but that was not feasible due to COVID. Teleconsultation for physiotherapy was started. The pain and the paresthesia persisted, and he was unable to walk. This the MRI shows the hematoma. The MRI showed increased T2 signal intensity in the right iliacus and diffusely increased T2 signal of the right pectineus in the vastus. There was femoral neuropathy with quadriceps wasting. On physiotherapy under factor cover, he recovered partially and was able to bear weight on the lower limbs and was able to walk with support.
So this is the MR which shows an iliacus collection. It's an old bleed.
So this case is presented to show a patient of hemophilia B, who had a recurrent psoas bleed, and there was a residual neurological deficit due to the bleeding.
So from simple bleeds to target joints, now we have a child who has gone on to have a deficit now. So Dr. Uday, psoas bleed is one of the most dreaded musculoskeletal bleeds. So when a patient comes in with pain in the hip or pain in walking, how do you differentiate it from a bleed which in the hip joint or an abdominal wall bleed?
Generally, a child who is not ready to stand straight or who is keeping his legs folded through and through. And once we ask the patient to lie down on a couch, if you are not able to straighten the legs of the child, so these are the indicators that the patient generally has got a psoas bleed. And as Pamela ma'am has previously told, it's one of the core muscle bleed. So it has got huge significance because it can have long-term morbidity in the form of difficulty in walking and having contractures and having severe neurovascular compromise. So as has been brought out on the slide as well, so the hip is generally kept flexed, pain on extension, but not on the rotation of the hip joint. So when a patient has a pain on rotation of the hip joint, that suggests a hip bleed or a hip arthropathy, whereas a iliopsoas bleed generally does not have a problem in rotation. And if there is any femoral nerve compression in the form of loss of patellar reflex or quadriceps weakness, as was present in this particular child, they are again they suggest that the child has a iliopsoas bleed.
And it's pretty dangerous because untreated or poorly treated ones can lead on to femoral nerve palsies, which can be quite disastrous. So again, Dr. Pamela, in psoas bleed, what is the difference in rest and physiotherapy that you would advise? I think, ma'am, you are muted.
So one of the most important things in acute management of iliopsoas bleeds is we want to minimize femoral nerve damage. I think that should be the main focus, okay? And you can do this by good positioning early on. I have a young boy with me here who's been patiently waiting with us to see if we use him. Shall I show you the position for psoas bleed? Do we have time?
Yes, sure.
Huh?
Sure.
Yeah, come. I'll show you. Show it on, Abhishek. Right now. You can say hello to all of them. They're all hello, hello. Okay, come. Just lie
Hi,
down.
Abhishek.
Yeah, just lie down. So we'll assume that he has a problem in the right iliopsoas. Can you see? Can you all see?
Yes, ma'am.
Okay. So normally they will have severe pain. Can you just arch your back a little bit as if you have psoas bleed? Yes. So they'll have an arch in the back because the iliopsoas is a retroperitoneal structure. Severe pain. They won't be able to get their back flat on the bed and they may be holding their leg like this, right? So the first thing we want to do is relax the pelvis. So what I will do is just relax. Yeah. And then we will put some pillows or cushions to keep the limb in the position of comfort that he is comfortable in. It might be at 90 degrees, it might be at 60 degrees of flexion, it may be even straighter. But this is the position that they should maintain and they need a pillow under the legs. Often the leg will be left like this when they're not advised. And when this back is also arched, the femoral nerve will be under great deal of traction. So from a neuropraxia, it can go on to even being affected at a grade 2 level, and then it will take up to about 6 months to recover. So this is a very, very simple way of saving the femoral nerve while factor works and the bleed begins to resolve and the pressure on the nerve is released. I thought that's something which is very easy and simple for people to advise in the OP.
Yes, very true.
Now, and this is one bleed that requires complete bed rest, as Dr. Uday also said earlier. We should not be in a hurry to get them up and going. This is one bleed where you need imaging. So usually a CT pelvis will help later. Acute phase, we can use an ultrasonogram also to look at the size of bleed, see if the patient is responding to the factor therapy, etc. Once we feel that the bleed is actually receding and it comes down to a sort of minimal size on USG or CT, then we allow them to begin to load the limb, and that too with a walker. So this is again one muscle bleed where you don't go to direct full weight bearing. You start off strictly with partial weight bearing, because the big problem in iliopsoas is there's a very, very high chance of recurrence, unlike other muscle bleeds. So recurrence is a huge problem, and recurrent iliopsoas bleeds are very, very difficult to treat. The psychosocial ramifications are very intense. because you're completely bedridden. So everybody's stuck around you, depression, so many issues begin to roll in. So this is one bleed you don't want recurrence. And how do we prevent it? With positioning. Common problem. They're all resting at home, will be in one position. So they'll have it, supposing, for example, in this case, the TV was where the laptop is, and Abhishek wants to watch TV because he's on rest. He will turn happily and lie on the right side. So the pressure will worsen the bleed. So this is very important to tell them not to lie on the bleeding side. They would lie on that side because they've got, often will have some neurological compromise, they can't feel. So they lie like that. So very important to tell them not to lie on that side, that they're bleeding. So these things will really help save the nerve and help with good steady recovery. In the subacute phase, our main interest is to maintain adequate soft tissue and muscle length. Because as things heal, there is a tendency for fibrosis to happen. And then the fibrosis will induce a deformity across the anterior hip, which will cause a number of biomechanical problems across the flank on that side, as well as in the ipsilateral lower limb, and can lead to other joint bleeds, especially if the quadriceps is compromised. So you can expect that 6 months down the line, you'll have a target knee there. So very, very important that you work on this. And lastly, you should follow them up until they get full length recovery of strength and function in the quadriceps and both lower limbs.
Okay, ma'am. Thank you. Very, very important points, because this is one joint bleed which can lead on to disability in patients, in many patients who are not treated properly. And I think this will be our last case. Ravi, are you there? I'll present the case. I think Ravi.
Our fourth case is a 4-year-old boy who is a known case of severe hemophilia A, diagnosed at 7 months of age. There is no known family history of hemophilia. He had episodic factor replacement. His annualized bleeding rate was 8. There was oral bleeding in left ankle and both knee bleeding during the 2 to 3 years of age. He completed vaccination on schedule and he completed 22 exposure days. On September 2019, he presented with right ankle bleeding since 2 days. Factor 8 was replaced at 250 units per day for 3 days. There was minimal improvement and the pain and the joint swelling persisted. Inhibitor screening was done. We showed APTT of 83.9 seconds and the control of 31 seconds. Baseline mix was of 43.2 seconds. After 2-hour incubation, fresh mix was 57.2 seconds and incubated mix was 77.9 seconds. Bethesda assay was 52 Bethesda units. So the options for the treatment for this child was bypassing agent on demand with immune tolerance induction, bypassing agent on demand, bypassing agent prophylaxis, and non-factor replacement treatment. He was started on bypassing agent on demand as factor was not available for immune tolerance. Fever was administered for right ankle bleed at 60 units per kg, single dose. He responded with the improvement of the joint. There was annualized bleeding rate, however, increased while on episodic bypassing agent. For the next 6 months, he had multiple joint bleeding, right source bleed, and oral bleeding. He was switched to emicizumab at 3 mg per kg once in 2 weeks and later once in a month. Presently, is 4.5 years and he has received emicizumab for 30 weeks. Before emicizumab, he had annualized bleeding rate of 16, and on emicizumab, he has annualized bleeding rate of 0.
This is a high titer inhibitor, hemophilia A, where ITI, as in most of our patients, for most of our patients, is not feasible. So, Tulika ma'am, just quickly, could you tell us when do you test for inhibitors in patients with hemophilia? When all would you ask for a test?
So when we start prophylaxis, it is important to screen these children for inhibitors, not because prophylaxis causes inhibitors, but because they have not been exposed to it and they may develop a transient inhibitor. The protection that prophylaxis gives you is long-term in reducing the inhibitor risk, but that protection only happens after about 30 to 50 exposures. Before then, some of these children may develop an inhibitor. Also, whenever you find that you're not getting an adequate response, or you're, those are the times that you should check. Before you are doing any major surgery, always check, even if you've checked recently. And so at any time when you're getting a suboptimal response, but the initial thing is really important, because if you diagnose a transient inhibitor, you can kind of manage these patients very carefully, and you may prevent them from developing a high titer inhibitor, which is a very serious problem.
Yes, ma'am. So that brings me to the lot of doubts about inhibitor testing. Srimati ma'am, when you test for inhibitor, what are the tests that we should be asking our pathology colleagues? And there are patients with low titer inhibitors, so sometimes that can be missed on our screening. So how do you, what do you advise in order to not to miss those low titer inhibitors? I think lupus anticoagulant, you mentioned in detail. So could you brief us as to how do we test for inhibitors?
Yeah, though WFH guidelines is there for quite some time that we should not be going for APTT-based mixing studies as a screening test for inhibitors. It's been very difficult for most of the labs to go directly for the Bethesda assay, because I think very few labs in the country are doing Bethesda assay. So people are still doing APTT-based mixing studies, but it doesn't match with the WFH guidelines. They are strictly against APTT-based mixing studies. So now what we have done, we have an inhibitor screening project for the Western India, where CMC, Sahyadri and our institute are part of this project. In that we have a kind of, it's not the APTT based. What we have done is we have a 2 dilution Bethesda assay. So only if they're positive, then we go with further dilutions. We don't put in a series at one stretch, we don't put multiple dilutions. This is a screening. At the same time, it is highly sensitive to pick up even the low titer inhibitors. Little expensive than the, definitely more expensive than the APTT based screening assay, but it doesn't miss any of the low titer inhibitors. So I think this should be followed by all the laboratories. Number 2 is, what is the question number 2?
Question number 2 was on low titer inhibitors, how not to miss them.
Yeah, NBA by clot-based assay, NBA followed by chromogenic assay would be the ideal gold standard assay for not missing any of the inhibitors, even extremely low. But I am not very sure how many. I mean, it's easy to say that chromogenic, Nijmegen, none of the labs are doing this. So combination of these two is highly impossible for the labs to follow. But the gold standard test, if you're having any research project, the gold standard test, not to miss any of the low titer inhibitors, is Nijmegen followed by chromogenic assay, not the clot-based assay. And
so which children are at high risk of inhibitors? So when a family comes in, how do you know that these children should be tested and they should,
there are definitive guidelines put, I mean, the first 20 exposure days, I mean, as far as the genetic risk factors are concerned, mutations are the strongest risk factors for, this is where you want to know the mutation. If a family insists, you may have to do the mutation to see whether he's got a high risk mutation for inhibitor development. Because in one of our studies, of course, all these risk factors like race, family history, factor VIII mutation, but there are contradictory reports. In different reports, there are contradictions about the rest of the things, but mutation has been found to be a strongly association in all 100% of the studies reported so far. Now, this is our study. I just want to show you, if you see the large deletions, which we had about 8 cases, all 8 cases have developed inhibitors. This is a small series of 70 inhibitor positive patients. And among the intron 22 inversions, 50% of the inversion positive cases had inhibitor. So null mutations have a strong predisposition for inhibitor development. And if you see the missense mutations, it's negatively associated. 1 out of 70 as against kind of 15 against inhibitor positive. So missense mutations are negatively associated with inhibitor development, and deletions and inversions are strongly associated with, positively associated with inhibitor development.
So there is family history of inhibitors. Definitely.
There is a definitive risk of inhibitor development.
So Dr. Uday, Ravi just mentioned the options for treatment. How do you decide how to treat a patient with inhibitor positive hemophilia?
So the most important thing is the lab report, whether the patient has got a low titer inhibitors or a high titer inhibitors. If the patient has got less than 5 Bethesda units, he would be labeled as a low titer inhibitors, wherein these inhibitors act very weakly and they do not neutralize the recombinant factors or the plasma derived factors very quickly. So in these patients, we can still go ahead and give high doses of the factors, whereas in high titer inhibitors, the patients generally, they have strongly acting inhibitors, they quickly neutralize the factors, and most importantly, with every additional dose of factors that we give, the titers going high. So it's important to differentiate low versus high titer inhibitors, with a small caveat, as was already brought out by Srimati Shetty ma'am, that it's very difficult for lab to give a report of low titer inhibitors. Most of the reports that we generally get is only of the high titer inhibitors. Secondly, a patient, even if once has more than 5 Bethesda units, would be labeled as high titer inhibitors, irrespective of his inhibitor levels going up and down. So even one level of more than 5 would be considered as a high titer inhibitors. So depending upon whatever the patient has, if he has low titer inhibitors, then the factors can be given. Whereas in high titers, we have to give bypassing agents. Now, for hemophilia B, though the theory says that we can give factor 9 in low titer inhibitors, but there is a additional fear of anaphylaxis or nephrotic syndrome in these patients. So we have burnt our fingers once. So we should be very careful in giving factor 9 to any patient who has got a factor 9 inhibitors.
Yes. And would you, so how, what is your experience on immune tolerance index?
Only person in the country to have the best experience is Tulika ma'am about immune tolerance induction, because ma'am has successfully treated few of the patients with ITI. These are the various protocols which are noted down here, but I would request ma'am to just add a small snippet about her experience on this.
The only thing I would suggest is, if you are planning ITI, you need to select the right candidate. So younger children, people who have not got a very high historical titer of inhibitor, who've not had the inhibitor for a long time, these are the better candidates. So if you select the good candidate, that is a best thing to do. The other thing is to use emicizumab. So for at least for hemophilia A patients, we have emicizumab, and we have managed an inhibitor child with a very high inhibitor titer, bilateral pseudotumors. And in fact, Neeta had helped us a lot, because this patient continued to bleed even on bypassing prophylaxis. And there's actually a little bit of a discussion on whether ITI should be even done or not. So that is an interesting thing. It's not completely sorted out as yet whether we should do ITI, but I think the WFH so far still says to try to attempt ITI. If patients fail ITI, then you can again go to these non-factor products.
Okay, I think we'll skip a couple of questions, ma'am, and we'll come to the last bit, which is basically on last two questions, which are quite significant in terms of what is your one is on experience of non-factor replacement, because there are many queries that are coming in now with the availability of products in India for both hemophilia A patients and inhibitor positive hemophilia. What are the agents that are available?
So one agent that is available and approved in India is emicizumab, and emicizumab is a bispecific antibody which kind of bypasses your factor 8, and it is equally effective in patients of hemophilia A with inhibitors or without inhibitors. The only thing you need to remember is that this is prophylaxis. So if a patient has an acute bleed, they need to get treatment. And if they have no inhibitors, you can treat these patients with factor 8. And if they have inhibitor, you should only use recombinant factor 7A in these patients, because this is a very strong product. And if you use fever or you use high levels of recombinant factor A, you may actually end up with thrombosis, which could be life-threatening. So if you have an inhibitor, use 50% dose of recombinant factor 7A for these patients. Unfortunately, it does not work in hemophilia B. In hemophilia B, we have a new product called concizumab. So concizumab is an anti-tissue factor pathway inhibitor, and we've been fortunate that we have been on a trial for this. This is also a subcutaneous product, and this works in both hemophilia A and hemophilia B patients. So this is also a very exciting agent. Again, there is a risk of thrombosis. The study was halted for a few months because they had an international patient who had developed thrombosis. So there are a couple of other new products like fitusuran, which is coming. It's a small interfering molecule. It is an antithrombin, and it generates thrombin. There's also an RNAi targeting antithrombin 3. So there's a lot of new things that are coming up. The advantage of some of these newer products, like the fitusuran and RNAi, is that they can maybe even be used in other rare bleeding disorders where you have like other factor deficiencies. So it's a very exciting time. The only problem is, as I said, these are much stronger than what products we used to have. So you need to use them carefully and cautiously. In case you need to do monitoring, then you need to do the chromogenic assay, as Dr. Srimati Shetty had described. So monitoring is still an issue, but they're very exciting.
Exciting times ahead. And I think that brings us to our last question, Dr. Uday. There's a lot of buzz about gene therapy. It's no longer buzz, actually, it's the reality. And so what are your expectations for our country? Just briefly, if you could describe gene therapy for hemophilia and the expectations.
So definitely it's a quest for cure, and most of the patients nowadays, they come to the OPD and they first ask, are you starting gene therapy? Is it available in your center or not? So, but definitely it's not as simple as. So there's a difference for the students. First thing, there's a difference between gene therapy and cellular therapy. In gene therapy, we are trying to induce a modified gene into the normal genetic makeup of a human being and trying to allow these cells through vector or through cellular, through genetic engineering to go and sit in the liver. Why liver? Because that is the organ which creates most of the factors. So we make most of these cells or these engineered products to home on to the liver, and there we allow these things to replicate. Now, the product that we are sending inside, either it could be because it's a monogenic disorder, it could be the absent gene per se, or it could be adjuvant wherein it has more potency when compared to the normal genes that we generally put in, or the normal genetic makeup. For hemophilia type B, it's slightly easier than hemophilia A because the genetic defect is a smaller one. We have to induce a small component of the genetic thing into the cells, whereas in hemophilia type A, the amount of gene that has to be put in is a huge one. So the vector that we require has to be accordingly large enough and has to make sure that it goes and homes in properly. So trials are on across the world. As on date, there are not more than 50 patients who have successfully been treated with gene therapy till date. The trials have started in our country as well, wherein CMC Vellore is the center where the gene therapy is going to be launched through a proper national trial. But still, as of our country is concerned, it's still a science fiction. Yes, as Dr. Neeta mentioned in the initial part of our lecture, it could be seen during our lifespan, but not maybe in the immediate future. So let's wait. How long is our lifespan or the patient's lifespan to see if this comes to be a reality, but we all wish to, because this is definitely a cure for hemophilia.
Thank you, Dr. Uday, for that brief description. So I think we'll wind up here, ma'am. We have really taken a lot of time, more than what was allotted to us, and Sunil had to leave as well. So we'll take up prenatal diagnosis and some topics which we have left in one of the upcoming sessions.
Sure.
And I thank all the panelists. Really wonderful to hear from you, learn from you, and I hope the students have taken the advantage. Let me just see if there are any questions in the chat without, no. There is something about, okay. There's something about surgery, screening for hemophilia before routine surgery. I think that has already been replied. Okay. And there was one message about counseling of families. I think I don't know if Dr. Revati is still there in the group, but maybe we could discuss, Tulika ma'am, like how when you counsel, no, like this is basically to parental counseling. So a lot of mothers feel guilty about the fact that this has come from the maternal side. So how do you typically counsel a family regarding that? Ye kyun hua, that discussion.
So the way I counsel is I say that the origin, because most of the time there's a family history. So in those families, I say that the gene, the mutation occurred in the man. So I kind of start off the different way. And I say that the woman is a carrier. So she carries this mutation gene. So it may not be the absolute truth, but I think in Indian families, we kind of have to kind of make it so that she's not the main culprit. She's just a carrier. It is a very difficult issue. And
no, you are right also, Tulika, because the mutations, because 40% of the mutations take place in the maternal grandfather. So its origin is man. Like most of the inversion mutations are taking place, and the mothers are silent carriers. So
the daughter of a hemophilia is an obligate carrier, so she has no choice.
That's right.
Thank you. So that's how I do it, and that way I often find that the husbands and the in-laws are more able to digest it rather than, she is the defect. So that's how I do it. But we get a lot of questions from families, and I'm so glad that Srimati ma'am is here, because we get a lot of questions from the hemophilia families because they want carrier testing for the prenatal testing for the carrier female. And I tell them
that is one thing. I mean, we might have done around 3,000 to 4,000 families. Each family across the table has sat and asked me, can we get a carrier female report? Now, I say that, I mean, the way I counsel is like, I mean, the female child is as normal as you are. So do you want to terminate such pregnancies? And the second thing is the government is not allowing us to give such reports, but is indirectly a sex report. So that is not allowed at all. I mean, throughout the world, it's not being given anywhere. So, but some people fight with us. There are a lot of things going on. People have gone legal. There are a lot of issues with each family, but it never happens.
I have a doubt, like in the prenatal act, the prenatal sex determination, the PNDT act, do they allow a sex determination in X-linked disorders? Like, are we allowed to know the sex of the baby to avoid a PVS?
Yeah, we are. I mean, the radiologists do tell us, but then we don't go by that. Okay. Because that is 80 to 85% accurate. It's not 100. I mean, suppose a family comes in late pregnancy and the radiologist says that it is XX. We can't go by that because it's not known to be 100% accurate.
Okay. And one more last question, Dr. Uday. There's a question as to if we have given cryo or FFP, is that counted as an exposure day?
Yeah, definitely. So yes, it is. It is counted.
Yes, so that also has to be documented. So although we don't, nowadays the requirement for cryo or FFP is drastically less for this group of patients, thanks to the support from the government and from World Federation of Hemophilia. I think we'll wind up here. Thanks a lot to all the panelists for.
Where is the feedback form, that link? All right.
Feedback form link is there now.
All right. Okay.
Thank you very much.
Thank you, Neeta. Thanks a lot.
Thanks a lot, Dr. Neeta, for doing such a wonderful session.
Yeah, it was a very good experience.
And I hope we have very few participants left. I hope they've, they do. I'm sure they did as well.
No, you started off with a big number, probably, and we have exceeded the time too.
Thank you very much. Thank to all the delegates.
All right. Bye-bye.
Bye bye. Stay safe.
Bye bye. Bye bye.